Good morning, everyone. My name is Wasim Balan. I'm one of the infectious diseases physicians, and this morning I want to thank you for joining us for today's Grand Rounds, and it is my tremendous pleasure to introduce a friend and a colleague, Dr. Banerjee, who is currently actually on a sabbatical in Singapore. So it's 10:30 p.m. over there, 7:30 a.m. here, obviously. So good morning for us. Good evening to you, Ritu. Dr. Banerjee is a professor in the Division of Pediatric Infectious Diseases at Vanderbilt University Medical Center, and she's actually the Executive Medical Director of the Antimicrobial Stewardship Program at the Vanderbilt University Medical Center. She received her MD and PhD from degrees from Washington University in St. Louis, and then completed the pediatrics residency and her pediatric infectious diseases fellowship at University of California, San Francisco, where we actually met and worked together as fellows. And now, twice a year, we get to relive some of those times when we see each other at conferences. In addition to being an active clinician, Dr. Banerjee conducts NIH and CDC-funded clinical research about antibiotic stewardship, implementation and outcomes of rapid blood culture diagnostics, and interventions to combat antibiotic-resistant organisms, often in international settings. She is a member of many national committees through the Pediatric Infectious Diseases Society, the American Academy of Pediatrics, the Infectious Diseases Society of America, and the Antibacterial Resistance Leadership Group of NIH. Dr. Banerjee will speak on diagnostic stewardship, which is actually a very timely topic for Phoenix Children's, as Dr. Dennis Steetson, the Division Chief of Pathology and Lab Medicine, who is in the audience today, has recently launched the Lab and Diagnostic Stewardship Committee. And some of you should have already started experiencing some of the work that is being done through the committee. So without further delay, please join me in welcoming Dr. Banerjee.
Great. Thank you all so much. Thank you, Wasim, for that invitation to speak and for that introduction. I am delighted to be here virtually. I'm sorry I could not be there in person. And also really thrilled to hear that you have a diagnostic stewardship committee. So not many places have that. So this is terrific. I am going to go ahead and get started. If I can advance my slide. So my research is supported by CDC and NIH. I have no other financial disclosures. And I hope that by the end of this talk, you'll be able to do a few things: define diagnostic stewardship, understand how diagnostic stewardship impacts antimicrobial use and antimicrobial stewardship, and then identify opportunities for diagnostic stewardship within your own practice. Okay. So by way of background, I think it would be useful to explain to you how I got interested in diagnostic stewardship. So I come as an antibiotic steward, very interested in thinking about how to tackle this problem of antibiotic-resistant bacteria. So this is a schematic on this left side of the graph of the slide that shows you that the percent of antibiotic-resistant bacteria continues to increase over time, while at the same time, the number of effective antibiotics we have to treat these bacteria continues to decline. So this is a perfect storm that's causing the other pandemic, or the silent pandemic, known as antimicrobial resistance, or AMR. Now, CDC and other agencies have quantified the burden of antimicrobial resistant infections. In the US, and this is old data now from 2019, AMR, antimicrobial resistant infections, sicken over 3 million people per year, cost above $35 billion per year in healthcare costs, add more than 8 million hospital days. And if AMR continues to emerge unabated at the current rate, it's projected that by year 2050, there'll be more than 10 million deaths due to AMR. And as you can see on the right-hand side of the slide, this 10 million deaths will surpass all deaths due to cancer. The Lancet published a very interesting report a few years ago that also quantified global deaths from antimicrobial resistant bacteria. On the left-hand slide, you can see in purple the number of deaths that are associated with resistance, and in dark purple, then the number that are attributable to resistance. And most of these infections are lower respiratory tract infections. You can see in the left-hand tallest bar, otherwise known as pneumonia, followed by bloodstream infections, and then intra-abdominal infections. And each year, it's estimated there are more than 7 million deaths associated with resistant bacteria. 7 million deaths associated with bacterial infections. 5 million of them are associated with resistant infections, and 1.3 million are associated with bacterial pathogens that are resistant to all antibiotics. Okay. Now, deaths attributable to AMR per year by 2050 are unevenly spread throughout the world. So these circles on this map represent the number of deaths. So you can see the areas of the world with the greatest numbers of deaths attributable to AMR are in Africa and Asia. North America, where we are, a relatively small burden of death due to AMR. Okay, but in the US, we do have antimicrobial resistance threats. These are highlighted here in this report from CDC. Carbapenem-resistant Enterobacterales, or CRE, carbapenem-resistant Acinetobacter, Candida auris, MRSA, VRE, multi-drug-resistant Pseudomonas, extended-spectrum producing Enterobacterales. These are all very difficult to treat infections. And one of the biggest drivers of expanding AMR is antimicrobial use. Now, much antimicrobial use is appropriate. You need antibiotics to treat infections, but there is a substantial amount that's also inappropriate or overuse of antimicrobials. And this is a picture of Alexander Fleming, who discovered penicillin in the 1940s. But by 1945, he was already warning us that the ignorant man or person may easily underdose himself, and by exposing microbes to non-lethal quantities of the drug, make them resistant, okay? So we have a lot of inappropriate antibiotic use in the United States. It's estimated that at any given time, about half of inpatients receive inappropriate antibiotic prescriptions, and about a third of outpatients receive inappropriate antibiotics. And by inappropriate, I mean wrong dose, wrong drug, wrong duration, or sometimes they're receiving drugs for conditions that don't need antibiotics, like viral infections or a culture that reflects contamination rather than a true infection, okay? So all of this inappropriate antibiotic use is helping to drive up emergence and spread of AMR. And I just wanted to highlight here that 90% of our antibiotic use is in the outpatient setting. And so this is a map showing you there's tremendous geographic variability in antibiotic prescribing rates across our country. So the darker blue colored states in the Southeast have the highest prescribing rates per 1,000 patients. And I've circled in red where Tennessee is, where I live and work. You in Arizona, your prescribing rate is 632 per 1,000 patients, which is much lower than it is in Tennessee. So good job. So what can we do about this? So back in 2015, President Obama, under his administration, had a committee to combat antibiotic-resistant bacteria, and they put together a national action plan, which had 5 goals. And among them are strengthening antibiotic stewardship. And I won't go through all these goals, except to highlight that goal number 3 was advancing development and use of rapid and innovative diagnostic tests. So that is how I got interested in diagnostics and diagnostic stewardship to combat antibiotic-resistant bacteria. So let's talk a little bit about diagnostics. So William Osler, very famous doctor, said there are 3 phases to treatment: diagnosis, diagnosis, diagnosis. So if you can get the diagnosis right, hopefully you can get the treatment right. So we love diagnostic tests for this reason, right? They can help us get the diagnosis right. But then another very famous doctor and also author, Dr. Atul Gawande, has written about how there's an epidemic of overtesting, overdiagnosis, and overtreatment. And in fact, lab tests are the most rapidly growing part of the healthcare budget. And it's not always clear that all of these lab tests add value to quality of care and patient outcomes. And if they don't add value, then they just increase costs and really contribute to waste in our healthcare system. So this leads to this concept, this principle of diagnostic stewardship. So what is diagnostic stewardship? So this schematic I find to be very helpful. So everything starts with the patient. And there's a clinical evaluation of the patient. And somebody says, we need to order the right test for this patient at the right time. That's essentially diagnostic stewardship. So that test is ordered. The laboratory performs the test. The laboratory then reports the result of this diagnostic test. And then clinicians, hopefully with the help of an antimicrobial stewardship team or clinician, will act upon that result. And that is a circle then that helps us get the appropriate diagnosis and treatment for the patient. So you can see diagnostic stewardship and antimicrobial stewardship go hand in hand. But the real question that I was interested in is, can diagnostics help us use antibiotics more judiciously and thus combat antibiotic-resistant bacteria? So this is another way of looking at the diagnostic pathway. Again, you start with the patient at the top. A clinician assesses the patient and decides to order a test. There's all sorts of things that go into test ordering. How you use the EHR, how you list indications or provide nudges within the EHR to help clinicians order the right tests at the right time. Then the specimen's collected and transported to the laboratory. Of course, that needs to be done correctly under the right conditions in the right containers, transported in a timely way. The laboratory must perform the test correctly, report the results in a way that clinicians understand and can act upon. Okay, so this is a complex process. And I'm going to give you some examples and start with test reporting and aids to help clinician interpretation of test results. So, for example, let's start with an infant with sepsis who's in our neonatal ICU. And the question is, so this little baby maybe had some hemodynamic instability. People are concerned the child might be developing an infection, potentially a bloodstream infection. So blood cultures are collected along with other labs, and empiric antibiotics are started. But what antibiotic should you prescribe? Now, this is really important that you get it right, because on the right is a seminal study that showed, this is in adults, but we extrapolate to children, that for every 1 hour's delay from the time of hypotension onset until initiation of effective antibiotics, the odds of death increase quite dramatically, right? So it's really important to get the antibiotic right. The challenge here is that it takes a really long time to know if there's anything growing in the blood culture of that child and what it is, right? From the time a blood culture is drawn and sent to the lab, put on the blood culture instrument, incubated so that there's bacterial growth, and then stained and then subcultured, and then all the traditional tests are done to identify the organism and the antibiotic susceptibility test results. It can take anywhere from 3 to 5 days. And during that whole time, your patient is on empiric antibiotics. And if you haven't chosen the right antibiotic, that leads to poor outcomes for your patients, right? So fortunately, there have been a lot of analytical advances in blood culture technology. So we can identify things much more quickly today, hours instead of days from the time a blood culture turns positive. So we have some tests that can identify organisms directly from blood without even relying on culture. Most tests that are used in most clinical labs in the US rely on first a blood culture growing, but then there's rapid ways, PCR-based methods or mass spectroscopy-based methods to get organism identification, and also some susceptibility information. And then there's also rapid methods to get faster antibiotic susceptibility test results. Okay, so we can really shorten, compress the time from a blood culture from when a blood culture is collected until we get results to clinicians now. But does it make a difference? Do faster, more expensive blood culture diagnostics make a difference for outcomes for patients? So this was previously studied as of a few years ago, mostly in small observational investigations. And these really taken together provided mixed results, but they were very heterogeneous studies. They looked at a mixture of pathogens, resistance, implemented the test in a variety of different strategies. All of these studies demonstrated that using a rapid diagnostic test for blood cultures shortens the time to organism detection and the time that clinicians get patients on optimal therapy. So that's good. Many of these studies did not go on to evaluate further clinical outcomes, however. So results were mixed. However, there have been some randomized controlled trials evaluating outcomes using blood culture diagnostics. And I show you here a list of 10. There's probably 11 or 12 now. They used a variety of different tests that you can see in the leftmost column. The actual test they used does not really matter. What I want to highlight for you is in this red box here in the middle. Almost all of these RCTs demonstrated decreased time to optimal therapy. So that's good. Almost none of these RCTs demonstrated a mortality benefit using a rapid test, nor did they demonstrate reducing the length of stay using a rapid test. So it's really, really hard to demonstrate these hard clinical outcome benefits beyond just decreased time to optimal therapy using these blood culture diagnostics. Now, I was fortunate enough to lead 3 blood culture diagnostic trials now. I'll just review for you the first one we did, which we started back in 2013 when this BioFire blood culture ID panel was first FDA approved. This test was one of the first multiplex PCR platforms out there for blood culture characterization. You can see there were a number of gram-positive bacteria, gram-negative bacteria, Candida species, and only 3 antibiotic resistance gene markers on this platform. This was version 1. There's now version 2 of this same platform that has several more antibiotic resistance markers. But we wanted to see if implementing this test in routine clinical care actually made a difference for patient outcomes. So we randomized, this was done at the Mayo Clinic when I was there, and we randomized patients who had positive blood cultures to receive evaluation using standard blood culture and susceptibility testing, which is in this green box, or the rapid blood culture ID test called BCID, or BCID plus the antibiotic stewardship team calling clinicians and encouraging them or nudging them to act upon the BCID results to change antimicrobials. So really, here's the results. I'm showing you the 3 different arms in 3 different rows, and time 0 is the time that the blood culture turned positive. So the first thing to note is time to organism identification, which is this red box, was much faster in the 2 rapid arms. Time to antibiotic escalation in patients who are on ineffective therapy that's the black triangle with the E in the middle. That was much faster in the 2 rapid arms compared to the control arm, almost a day faster. An antibiotic de-escalation, which is when patients are overtreated, they're getting too much antibiotic. And when you get the rapid blood culture test back, you can tailor the antibiotic to more targeted therapy. You can de-escalate the antibiotic. That de-escalation only happened faster when the rapid testing was paired with antibiotic stewardship review and follow-up with the clinical team. And that's the blue triangle there. Importantly, we saw no differences in mortality, length of stay, or costs between the arms. Okay. This result has been replicated in a number of other studies since then. And in fact, there's been a systematic review and network meta-analysis from colleagues in Australia who basically found that there's a mortality benefit when you use a rapid diagnostic test paired with stewardship, but not when you don't pair it with antibiotic stewardship team oversight. Okay. So that's a great way. Pairing a rapid diagnostic test with the antibiotic stewardship team, making sure clinicians act upon the rapid result, is a great way to nudge clinicians, into being better antibiotic stewards. Okay, so that's one strategy. What about test ordering? Because there's a lot of opportunities for more appropriate use of diagnostic tests when clinicians are deciding whether or not to order a test and which test to order, right? So in our pediatric ICU at Vanderbilt, there's a lot of overuse of blood cultures. I don't know if it's the same for you all at your institution, but often with the littlest blip in temperature, even without any other clinical worsening or hemodynamic changes, clinicians will often just order a blood culture. So this was a study. It was a multi-center quality improvement collaborative across 14 PICUs in the United States, led by Dr. Woods Hill at CHOP. And basically the intervention was each institution came up with their own guidelines for when to draw blood cultures in their ICUs, educated their clinicians about that, audited how compliant people were with the guidelines, and provided feedback to teams when they were not following the guidelines, and then continued to sustain communication about this with frequent emails. And what they found was across this multi-center collaborative, the number of blood cultures decreased post-implementation compared to pre-implementation. And the number of CLABSIs decreased, the number of days of broad spectrum antibiotic use decreased, and the number of new initiations of broad spectrum antibiotics decreased. And there were no significant differences in mortality, length of stay, readmission, or severe sepsis in the pre-implementation versus post-implementation period. So it was safe to do fewer blood cultures. Okay. What about endotracheal tube aspirate cultures? That's another scenario that we have in our PICU where we find there's overuse of respiratory cultures in ventilated patients, often because they just have kind of a pan culture practice when a patient has a little fever, even if there's no change in the chest X-ray, change in the vent settings, or other parameters that would make you suspect that they're developing a pneumonia. So this was also a study out of CHOP. Again, their interventions were creating guidelines for when it's appropriate to collect an endotracheal tube aspirate culture. They educated their clinicians, they did audit and feedback, and again, they did frequent emails. And you can see in this control chart that with multiple PDSA cycles, they were able to really substantially reduce the number of trach aspirate cultures per 100 ventilator days. Okay. Streptococcal pharyngitis is also a condition where we see a lot of overutilization of testing. And this is a great target for diagnostic stewardship. So we know antibiotics are prescribed for way more than half of visits with pharyngitis in ambulatory settings. We also know that group A strep is identified in about a third of children with sore throat and less than that in adults with sore throat. We also know that if you were to swab asymptomatic children who do not have sore throat, up to 20% of them would have a positive group A strep test result, meaning they're asymptomatically colonized. Okay. We have great diagnostics for strep pharyngitis. We, in the old days, relied heavily on rapid antigen diagnostic tests, which were quick, where they were point of care, but they had some lower sensitivity so that you had to follow up a negative antigen test with a reflex culture. We now have a lot of clinics that are using molecular or PCR-based diagnostics that are also quick, that are more sensitive, so you don't need to follow up a negative molecular test with a culture. Okay. We also have very clear criteria of when to test for group A strep pharyngitis, right? Usually there's sudden onset of symptoms. We don't want to test in children who are under 3 usually. And then typically they would have one or more of the features listed here. And importantly, we do not want to test when the patient has upper respiratory tract symptoms or viral symptoms, right? And the CDC has a nice cartoon here that I've shown on this slide. But unfortunately, there is a lot of off-guideline testing and treatment. And there are a number of studies, which I've cited here at the bottom of the slide, that demonstrate this. And one of the studies, up to 2/3 of patients who were tested for group A strep actually had one or more viral features. And then there's tremendous variability in utilization of the tests. And you can see that in this graph on the bottom right. This is from a large urban health system in the Philadelphia area. Each column represents a different clinic, and each dot is a different clinician working in that clinic. And what the y-axis is showing you is the rate of group A strep testing per total sick visits. So you can see that even within the same clinic, there's a wide spread across the dots, meaning the clinicians are ordering the testing at very different rates. And then lastly, I want to highlight that there's a lot of treatment despite a negative test or despite no test being ordered. In one of these studies, up to 40% of pharyngitis encounters that received an antibiotic prescription were not associated with a group A strep test. Okay. There are a lot of things we can do to try to utilize group A strep testing more appropriately and not over-test. And this clinic that was affiliated with Mercy Children's in Kansas City found a real reduction in group A strep testing for children with viral symptoms just through workflow changes. So they educated their staff, and importantly, they eliminated the standing order to perform a rapid group A strep test before a provider evaluated the patient. And they provided a lot of email updates. They helped clinicians understand how best to communicate effectively with families. And they also provided education to families about how not every sore throat requires a strep test. So workflow changes are another really effective strategy, especially in the ambulatory setting. In our own clinic, we have similar challenges with over-testing for group A strep. And so we're soon going to be piloting use of modified Centaur criteria scoring system and encourage clinicians not to get the test unless there's a high enough score using these scoring systems. Now, the Infectious Disease Society of America recently put out updated group A strep guidelines, and they actually do recommend use of clinical scoring symptoms to identify patients who are older than 3 years old. And if they have a low probability of group A strep pharyngitis based on these scoring systems, that would suggest diagnostic testing is not helpful in those scenarios. Okay. Sophie Katz, who's one of our stewardship clinicians at Vanderbilt Children's, is also going to provide individual clinician feedback about group A strep testing rates. And she's going to do this by comparing an individual provider's strep testing rate, shown here in the blue bar, to their clinic peers, shown in the light gray bar, to all of the Vanderbilt University ambulatory clinicians, shown in the dark gray bar. So this project hasn't started yet, but we'll be eager to see how effective this strategy is. Urinalysis, urine culture, we all know that this is also a common driver of inappropriate antimicrobial use because there's a lot of false positive results, meaning there's asymptomatic bacteriuria. And we know we should not, especially if we're not collecting the urine samples appropriately, which can be challenging in children, I know. But we don't typically recommend treatment of asymptomatic bacteriuria unless the patient is pregnant or about to have an invasive urologic procedure, right? We need to remind all of our clinicians that pyuria or even foul-smelling urine are not specific for UTI, and non-specific syndromes like leukocytosis, fever, fatigue do not need you to always get a UA or urine culture, especially in older children, right? Younger children who are nonverbal, of course, it's more challenging. Anyway, it's important to recognize with positive urine cultures, just like with positive respiratory cultures, it's very hard for clinicians not to treat them. There's a knee-jerk reaction to prescribe an antibiotic in response to any positive culture, regardless of the clinical scenario in which the culture was collected. So we overtreat a lot of these positive cultures that reflect contamination or colonization, right? So one thing we've done at our institution is try to do reflex urine cultures only after an abnormal urinalysis. So we use EPIC, and we have some decision support at the time that you're ordering the urine culture to say urine cultures are only available if you have an abnormal UA with greater than 5 white blood cells, except for certain exclusion criteria if you're under 2 years of age, pregnant, complex urologic history, or if you're neutropenic. So we've had this in place for quite a long time. I would love to evaluate how effective this is, and I would love to hear if you're doing similar things at your institution. In the remaining few minutes, I'd love to talk with you about syndromic multiplex PCR panels, because we have them for respiratory infections, GI infections, as well as CNS infections. So multiplex PCR panels are molecular tests that allow you to detect multiple pathogens from a single specimen. Often these are non-culturable organisms, and often you can still detect organisms in specimens that have had antibiotic pretreatment. They're fast, they're very sensitive tests, and some people would argue that for these reasons they're cost effective, but I have a question mark after that because I'm not sure it's been truly demonstrated that they're cost effective. But there are a lot of cons with multiplex panels too. Remember, a positive test does not always mean there's an infection, so they always must, especially because they're so sensitive, we must be really cognizant of interpreting results in the clinical scenario, in the clinical context. They have a limited number of targets, and they're fixed targets, so you can't customize, you can't pick and choose which targets you want to look for. Because they're so sensitive, there's potential for contamination. They cannot distinguish colonization from infection. They're costly, much more costly than standard testing, and they don't provide susceptibility information for the most part. Okay, so let's talk about some of these tests. So upper respiratory tract infection. We know most of these are viral. We know that viral upper respiratory tract infections account for 20% of outpatient encounters that receive antibiotics. So this amounts to more than 10 million visits per year. So huge burden of antibiotics that are given for viral URTI. We have lots of different pathogen detection methods. In the old days, we relied on culture or direct fluorescence or immunofluorescence or rapid antigens. And you can see the sensitivity was lacking with these methods. They also had longer turnaround times than were useful for ambulatory clinic visits. Now, of course, we have molecular tests, nucleic acid amplification tests, and multiplex PCR assays. They have much higher sensitivity, they're faster, but they're also more costly. Okay, so we have to ask ourselves, does rapid viral testing for children with acute respiratory infection in the ED change patient management? So these are 4 different trials looking at point of care flu diagnostics. And in a Cochrane review that's old now, that basically demonstrated that results were a little bit mixed. In previously healthy children presenting to the ED with fever and acute respiratory infections, rapid viral testing showed a trend towards fewer antibiotic prescriptions. So that's good. That's good stewardship, although it wasn't statistically significantly different. And a reduction in chest X-ray use. So that's also good. What about these molecular tests? Because I just said we're no longer really using antigen tests or direct fluorescence assays, but we're using molecular tests. So what do we know about the clinical outcome using these more expensive molecular tests? So this study pooled 15 different clinical impact studies, 5 of which were in the outpatient setting. And I've detailed out these 5 outpatient studies for you. None of them are RCTs. They're all single center cohort or before after studies. Some of them were looking just at flu. Some of them used the film array, which has over 21 different targets. And basically, some of them showed a slight decrease in hospitalizations, slightly more uptake or faster prescribing of oseltamivir for flu. But when you pool all the inpatient and outpatient studies together, implementation of rapid molecular tests for respiratory viruses had heterogeneous results. And really, this study couldn't say either way whether or not there was a benefit. And in fact, the IDSA, Infectious Disease Society of America Diagnostic Committee, actually has said respiratory nucleic acid amplification testing is most useful in the setting of intermediate pretest probability and intermediate disease severity, meaning when you have high pretest probability, say you're in the middle of flu or RSV season, and you have a healthy immunocompetent host, there's probably not utility in getting viral testing. Now, I mentioned several times that these molecular tests, while they're great tests, are quite costly. So and they're overutilized, okay? And certainly at my institution, they're overutilized. So can raising awareness of test costs actually reduce multiplex respiratory pathogen panel overutilization? There's a really nice case report published in JAMA Internal Medicine that talks about this. And the AAP had a Choosing Wisely campaign just a few years ago that basically says broad respiratory pathogen panels should not be routinely ordered unless the result will affect patient management. And actually, insurance companies are in agreement. So they basically have come out and said panels, respiratory viral panels that test for 5 or fewer pathogens are more likely to be covered by insurance. But panels with more than 5 pathogens may not be deemed medically necessary and therefore not reimbursed. I know at our institution, we've lost millions of dollars in denied claims for overuse of multiplex respiratory pathogen panels. So we're now looking at strategies to selectively to encourage clinicians to selectively use the broad multiplex panels with over 20 targets only in immunocompromised or high-risk patients or critically ill patients, but not in otherwise healthy children who will remain outpatients. Okay. There is a nice study that came out of UCLA that showed that EMR nudges that just demonstrate that some tests cost more than others can actually reduce ordering of the costly tests. So this was a pre-post intervention study, and gray is the pre-intervention period, where they 61% of their respiratory testing was the broad respiratory panel. Then they had reflex testing during the orange period, where they would start with an antigen test, and only if the antigen test was negative would they reflex to molecular tests. So that substantially reduced utilization. But then they said, actually, let's just use a non-interruptive clinical decision support, where within the EMR, we put $3 signs next to the very expensive test. And that alone reduced respiratory viral panel testing. So that's an interesting strategy that we hope we'll be able to implement at our institution shortly. A few more multiplex panels that are less widely used, but they're commercially available, so you should be aware. This is the BioFire Film Array Pneumonia panel. You can see it has extensive number of bacterial, viral, and atypical bacterial targets, as well as lots of AMR genes. It's FDA approved for use in BAL-like fluid, sputum, and endotracheal aspirates. Now, again, does this impact patient care in a meaningful way? It's very highly sensitive and specific. So one of the first outcome studies in pediatrics was conducted by Alex Plattner at WashU, where they implemented the BioFire pneumonia panel at St. Louis Children's without any restrictions or routine stewardship review. And what I've shown you here in the circled pair of bars is that When the test was ordered, the majority of the time, there was no change in antibiotic management, even though there was potential for change, which is shown in the black bar. Likewise, there was potential to stop the antibiotic on the very left-hand side of this graph, but there were more opportunities to stop, potential opportunities to stop, than the antibiotics were actually stopped in response to the test. So that test, it's an expensive test. It's utilized a lot. It's not really impacting antibiotic management, at least in this ICU. It's a challenging specimen type to work with, of course, because respiratory specimens are rarely sterile, right? So how will you determine if all of those targets that you can detect with very sensitive multiplex PCR actually are clinically significant? That's a challenge. Okay, there's a multiplex panel for GI pathogens. You can see lots of bacterial, viral, and parasitic targets. There are several FDA-approved panels from different companies, very sensitive, very specific. But again, does it make a difference for patient outcomes? I'm highlighting just 4 of these studies. These are, again, cohort studies or pre-post intervention studies. And the bottom line is all of them demonstrate increased organism detection, faster time to results. Many of the results are actually viral organism detection, and they don't necessarily impact antibiotic management. But we need to be very thoughtful about whom we test using this very expensive test. We really don't need to be testing everyone. So this is an example of what happened. This is what happened at our own institution, where we implemented the multiplex GI pathogen panel without any decision support, without any restrictions. And the date of implementation was this vertical dashed line that you can see here. And then ever since implementation, you can see the number of tests we're ordering at our children's hospital, inpatient and outpatient, continues to increase, although the number of detections of bacterial or viral targets shown in the blue and purple lines has been relatively stable. So all this additional testing we're doing, I would argue, does not add value, and you could consider it waste, right? So we have to walk back some of this testing at our institution and start to implement some restrictions, which is always hard to do when you've kind of opened the floodgates previously. And the last thing is that there's a film array biofire meningitis encephalitis panel. We have it at our institution. Many children's hospitals use this. I don't know if you have it at your institution. I'd love to hear about your experiences with this, but there are some limitations to note. You'll note the targets are really not reflective of organisms that cause healthcare-associated infections like shunt infections. And no tick-borne infection targets, which I always have to remind our residents. Where I practice, we have a lot of tick-borne infections in the summertime. This panel is not necessarily effective at ruling out tick-borne CNS infections, right? What do we know about outcomes using the meningitis encephalitis panel? Well, we don't know much. And the bottom line is sometimes with use of the panel, we get less acyclovir use. Sometimes we have fewer days of antibiotics. Some studies show a slightly shorter length of stay, but there are few studies, and we just need more studies to really understand what's the highest utility population, in what population would a test like this have the highest clinical utility, right? I also want to just highlight that interpretation of molecular diagnostics can sometimes be challenging, which is why we don't want to overuse them. So I'll give you some examples from my own practice. I was called about a febrile 3-month-old who underwent a full sepsis evaluation. The results of the LP were stone cold normal, no pleocytosis, normal glucose, normal protein, and a meningitis encephalitis panel test was sent. And it showed H. influenza. The CSF culture was negative. The child was not pretreated with antibiotics. How do we respond to this result? It's really challenging. Remember, molecular tests have high risk for contamination. So the first thing I did was call the lab and say, hey, are you seeing lots of H. flu contamination in your MEP tests? And then I think a diagnostic strategy that's very useful, maybe not in neonates and in real small infants in whom you can have meningitis without pleocytosis, but 3 months and older, we typically do not recommend using the meningitis encephalitis panel if there's no pleocytosis or no abnormal features in CSF chemistries. So that's one thing you can do to use the MEP more appropriately in a more targeted way in patients who have a higher pretest probability of meningitis. Another example, also from our practice, is a 16-month-old with fever who, for all intents and purposes, looked like she had a viral syndrome, rhinorrhea, lethargy, poor PO. She was admitted for observation and IV fluids, and a respiratory pathogen panel revealed adenovirus. So that's great. But 2 days later, she was still really febrile and sleepy, and the lab showed she had really high white count and really high CRP, right? The team had not started antibiotics because they thought, well, they were being very good antibiotic stewards. This was just adenovirus. But in fact, because of her ongoing lethargy, they did perform an LP, and in fact, it was abnormal, and she did have H. flu meningitis. So this is always a reminder, no matter what the molecular multiplex panel is telling you, always interpret test results in the clinical context, right? So I think this is one of my last slides. So I just want to highlight that there are several high yield areas for diagnostic stewardship and lots of key strategies. So one strategy is to put ordering restrictions or clinical decision support into your EMR at the time clinicians are thinking about ordering a test. So for example, we don't want to encourage C. difficile testing in children who are under 3 or in patients who are receiving laxatives. We don't want to do repeat endotracheal tube cultures in patients who've had prior cultures in the prior 48 to 72 hours. We don't want to do group A strep testing in patients with viral symptoms. We don't want to do respiratory viral, the broad multiplex pathogen test for respiratory viruses or GI pathogens in patients who are otherwise healthy and whom a positive detection of a virus would not impact your management, right? So all of these things, you can think about how to implement some ordering questions or restrictions at the time of order entry. Reflex testing, like don't get a urine culture in the absence of pyuria, or don't get the CSF multiplex test in the absence of CSF pleocytosis. Blood culture interpretation, when your laboratory detects a positive, an organism in blood culture, it might be helpful to think about if you're not doing this already, can you put some comments into the result report to guide clinician interpretation? So one thing that really worked in our trial is when we saw coagulase negative staph, we would put in this comment, possible blood culture contaminant. No antibiotic treatment is indicated for blood culture contaminants. And that actually led to less treatment of contaminants in our blood culture trial. And lastly, I think it's really important to think about putting diagnostic testing recommendations, embedding them within clinical treatment guidelines. So for example, many places don't believe that blood culture should be routinely collected when children are admitted with community-acquired pneumonia. So you might put that in your guideline. Or you might, like they did in that multi-center quality improvement project led out of CHOP, put some indications for blood cultures in your PICU sepsis management guidelines. So these are just some examples. There are many, many more. Okay. So this is my last slide. I just want to leave you with some take-home points. So the landscape for infectious disease diagnostics has been changing rapidly. There are increasingly available new molecular, highly sensitive, and excellent diagnostic tests for infectious diseases. They have great promise for us to improve the quality of care and impact outcomes for patients, but they also have pitfalls. One of them is cost. They're expensive. Another is that we should not be using them routinely. We should be using them thoughtfully in the right patients at the right time. So diagnostic stewardship is integral to antibiotic stewardship and quality of care. And I hope I've shared with you some key strategies that can encourage appropriate test ordering and interpretation, and thus maximize clinical impact. So with that, I'd like to thank some members of our stewardship team and our laboratory team, because it's very critical that stewardship and clinical micro work together to optimize diagnostic stewardship. So I really thank you for your time. I'm really looking forward to your questions. I'll stop sharing so I can see you all now. Thank you.
Thank you so much. That was great. And, obviously, as I said at the beginning of the talk, that this is very timely for us as we're, kind of troubleshooting and starting to work on some of this stuff. So any questions from the audience in the room? I actually just had a couple of comments just as a follow-up to some of your questions during the talk. So we're working on some of this stuff that you already mentioned, including the urinalysis with the reflex urine culture. At this point, we don't have that set up, but that's definitely something that we're discussing with microbiology. One of the other things that we started, which you will probably notice during your rounds and daily work on the inpatient side, is the reflex from the gram stain to culture for respiratory cultures from ET tubes. Before it was just any sample sent to the lab, will be cultured, but now the lab is going to be looking at the gram stain first and can reject the sample for culturing if it doesn't meet the criteria. The one question that I have, and this is, just kind of, looking at your experience from the community with some of the multiplex testing that happens. So, I mean, some of the common calls that we're getting these days are from pediatricians who are using some of the commercially available respiratory tests that basically have a very broad panel of, targets, including strep pneumo and some Neisseria species and Haemophilus, and their nasal swabs, basically, or nasopharyngeal swabs that they get. And then we get the call that they get a positive result when clearly the clinical background of the patient is, fits what sounds like a viral URI that's probably going to resolve on its own. But then they get this positive bacterial test result and they are seeking guidance. Are you witnessing this in your community too? Or what kind of, potential education to the community can you offer? Because most of the pediatricians, when you explain to them, the significance or lack of significance of those results, they obviously understand it then. But I think there's a push from, companies and their marketing teams in terms of, how wonderful those tests are, when in fact, they're going to lead to more antibiotic overuse.
Yeah, I totally agree. We are seeing use of these tests, many of which are actually not FDA approved yet. And we are seeing, patients come into our clinic saying, we can't get rid of the strep pneumo. It's always testing positive for strep pneumo. And then you have to say, well, strep pneumo is normal flora. It's normal. It's a normal part of your body, and it's not always a problem, right? So I totally agree that we need to get more education out to the community providers, clinicians about this. I don't have a great strategy to do that, but we're all now increasingly working in large health systems. And so we have larger areas and swaths of people that we can influence, who, refer to hospitals that are maybe more at least they're not in our urban areas, they're actually in rural areas surrounding our main hospital. So I think of that as a great opportunity, actually, to reach more clinicians who are practicing out in the community. We should probably strategize about how to do that so that we're not in a standardized way, so that we're not all having to reinvent the wheel, right? The other thing I would suggest, Wasim, as you're starting to do the reflex urine cultures, is you should study its impact, because I think for facilities like ours, which have already implemented that for some time, we can't go backwards in time necessarily and say what the impact of the test of that strategy is, because it's been in place for some time. But you have a great opportunity to study that.
Oh, that's a great idea.
We had 6 questions in the Zoom chat. I
Yeah.
thought it might be good to, why don't you introduce our, the new member of the stewardship team? Just so he
Oh,
invite him up, but for Dr. Banerjee, 2 people have asked about why not doing rapid streps on children less than 3 years old. So can you go over that reasoning?
Yeah, I mean, typically, unless there are extenuating circumstances like they are around older siblings who are school aged, who have strep pharyngitis that's bouncing around their classroom or in their household, typically children under 3 years of age don't get strep pharyngitis. It's usually a disease of school age children. So that the pretest probability of true strep pharyngitis is quite low in that age group. Now, if you see a child who's young, who has no viral symptoms, who meets all the criteria that we went over, sudden onset, very high fever, for exudate, all the things that make you really suspicious that this is actually strep pharyngitis, then I would say test, regardless of the age of the child. But most of the time, under 3, it's not true strep pharyngitis. That's why the guidelines are written that way.
One from our ID fellow. Excellent talk. Thank you. What has your experience been with metagenomic testing and achievement?
You'll notice that I did not mention that. It's a big can of worms. There's great potential, right? But most of the time, when in our experience, and I think most of the studies that are out there also say the same, is the yield is quite low. The majority of the time that you send metagenomic testing somewhere, it's specialized, referral labs, it will come back like 90% of the time with a negative result. So it's a very high cost test. So we need to be thoughtful about in what patient population should we actually use it, right? And we are settled on at our institution immunocompromised and trying to do it only after all of our conventional testing results are negative. And if we're still really struggling to figure out what the infectious pathogen is, then we would send it. And we actually have a diagnostic stewardship committee that is comprised of ID, neurology, laboratory, who get together to determine if it's an appropriate utilization of this test or not. And then we didn't even talk about this, but the results come back and it's very challenging to interpret sometimes, right? Because what you detect might not necessarily be the true pathogen.
For the audience, we're talking about mostly the Carious test, and there's a CSF test that's called Delve Bio that we sometimes use. Those are the metagenomic tests that we're talking about.
Okay. And then lastly, somebody asked about how do you deal with somebody who may have a viral co-infection that really has group A strep pharyngitis in addition? So,
I think
they also may be intermittent, may have a virus at the same time.
Well, okay. I think if they're not getting better in the time frame that you'd expect a viral infection to get better, then you give them return instructions to return and you reassess. But typically, we try not to give somebody too many infectious diagnoses at once.
And what did you do with that kid with the Haemophilus?
Oh, that's a great question. I think given the young age of the child, nobody was comfortable ignoring H flu in the CSF. Although we felt probably it was a contaminant because the child otherwise looked well, fever had resolved, CSF looked otherwise bland. No, I think people were not brave enough to not treat given the young age. And I don't think that there's a right or wrong answer there, right? It's a very challenging scenario.
Okay, well, we're at time. So anybody here who wants to come up, and then Wasim, do you want to just introduce the new committee?
The antimicrobial source, the diagnostics committee. So Dr. Dietzen, do you want to say a word and just
see your face.
Sorry, we'll keep you online for a second. I'm sure you met Dr. Dietzen in the past.
Yes.
So It's just
Yes,
like
she had the misfortune of meeting me in St. Louis last fall, where she came to give a talk at WashU, and I went back to visit. So less than 6 months ago, we formed a diagnostic stewardship committee. It's very immature. At this stage, it's comprised mostly of folks in the laboratory. Key personnel on a committee like this are folks that know the money involved in these things. The IT folk data is a big driver of what we have to do, and everybody knows our data infrastructure limitations, I'll say. So we're struggling through that. We plan to expand it. Our two primary guests at these meetings now are Dr. Balan and Dr. Abdel Noor, as we tackle my first target has been procalcitonin and the misuse of procalcitonin. So, and I have one question for Ritu, why she's here. We're exploring ways to modify behavior, and you mentioned a few of those, advisories and test interpretation comments and things like that. Do you find in your experience that carrots are better or sticks are better at modifying behavior? I'm a stick man myself, but
I think I think of a combination of both. I think what does not work is education alone. I think education and dissemination of why you're making certain recommendations or making certain changes in the EMR is important, but that alone never works completely. A hard stop in the EMR, or ordering questions in the EMR, or audit and feedback and saying you're ordering too many tests compared to your peers, plus education. Those are I think doing that in combination, but I don't think I think carrot and stick.
Okay. I'm a big fan of shaming.
I totally agree. Focus stewardship didn't work. It's not one alone doesn't work. You need to kind of have the combination and, kind of paint it in a collaborative type of, way to show why we're doing those decisions.
So if anyone in the room, anyone online has stewardship things that they want to tackle, call me and we'll put them on the agenda.
Let everybody.
All right. Thank you so much. Thanks, Ritu. Enjoy the rest of your time.